Bismillah ar-Rahman ar-Rahim. First of all, I'd like to thank the organizing committee for inviting me to give this lecture. Special thanks to Dr. Muhammad Aimer, and congratulations for the successful conference. Today we are going to talk about the coagulation correction prior to endoscopic management. So we usually have some questions before doing any endoscopic procedure, whether the bleeding related questions, what testing strategy for bleeding risk assessment is most beneficial for patients with cirrhosis, does pre-procedure prophylaxis to correct coagulation parameters and or platelet level reduce the risk of bleeding in patients with cirrhosis. The other issue is the thrombosis related questions. Is venous thromboembolism or prophylaxis indicated in hospitalized patients with cirrhosis? Should patients with cirrhosis be screened for non-tumoral portal vein thrombosis? What are the data on a specific anticoagulant therapies for non-tumoral portal vein thrombus in patients with cirrhosis? In patients with atrial fib and cirrhosis, is anticoagulation safe and effective? So these are different questions that you should ask patients with cirrhosis for. We all know that there is a rebalanced hemostasis in patients with cirrhosis between the platelets and the von Willebrand factor, the platelet count, coagulation factors and the anticoagulant factors and the fibrinolytic factors and the antifibrinolytic factors, together with the co-associated comorbidities like the portal hypertension, renal failure, anemia, sepsis, and whether they are exposed for whatever reason for antiplatelet or anticoagulants. So you have to classify the procedure into whether a low bleeding risk or a high bleeding risk. Like the endoscopic procedure, like the diagnostic procedures, variceal ligation, transesophageal echocardiogram, or the high bleeding risk, like the bronchoscopy with biopsy, colonoscopy with polypectomy, ERCP with a sphincterotomy, or whether the percutaneous procedures or the vascular procedures or others. According to the different societies, actually, and astonishingly, you don't have to evaluate routinely for INR, platelet count, fibrinogen, or the vesicoelastic hemostatic assays. Only the American College of Gastroenterology in 2020 checked for the platelet count to be more than 50, and the Society of Interventional Radiology for the platelet count to be more than 30, and the fibrinogen level to be more than 1 gram, or the INR more than 2.5. And most of the recommendations say that the INR, the activated pressure, thromboplastin time, the platelet count, fibrinogen should not be routinely evaluated to predict the bleeding risk. And they recommend potentially modifiable risk factors for bleeding should be addressed in the peri-procedural setting, particularly renal impairment, sepsis, anticoagulant, or antiplatelet agents. And they recommended investigating causes for thrombocytopenia only in those patients with platelet count less than 30. And we recommend against the prophylactic correction of abnormal coagulation parameters in the peri-procedural setting. They recommended no treatment to increase the platelet count prior to most procedures for patients with cirrhosis. They suggested strategies to increase the platelet count prior to very high-risk surgery only, and these strategies may include platelet transfusions or thrombopoietin receptor agonists for those patients with platelet count less than 30. So the proposed management algorithm for acute GI bleeders on vitamin K antagonists, you have to have an urgent clinical assessment resuscitation. If you do have an active bleeding with a shock, you have to stop the vitamin K antagonist and actively reverse the anticoagulation with vitamin K or prothrombin concentrate. And you have to check the INR every 20 to 30 minutes. And you have to have adequate INR correction to be less than 1.5 and recheck in 6 hours. If there is a significant bleeding without hemodynamic compromise, stop the vitamin K antagonist and actively reverse the anticoagulation with vitamin K. And get your therapeutic INR. If you still have supratherapeutic INR, consider prothrombotic concentrate infusion. If you do have minor rectal bleeding, for example, you should have potential outpatient management if the INR less than 5, omit vitamin K antagonists or close monitoring. INR between 5 or 9, you stop vitamin K antagonists or vitamin K. And INR more than 9, you have to stop vitamin K antagonists and give vitamin K. Proposed management algorithm for acute gastrointestinal bleeders on direct oral anticoagulants. If you do have active bleeding, shock, you should have a fluid replacement, stop the direct oral anticoagulants, consider hemodialysis for clearing the diaphragm, consider off-label use of prothrombin concentrate, and you may consider the emergent endoscopy. If you do have significant bleeding without hemodynamic compromise, stop the direct oral anticoagulant with fluid replacement. Consider endoscopy preferably after 12 to 24 hours. If you do have minor rectal bleeding, you do have potential outpatient management. Again, you have to classify the patients into low-risk procedure or high-risk procedure, together with an antiplatelet like clopidogrel or prasugrel or ticagrelor, continue therapy. Only if you do have a high-risk procedure like polypectomy, ERCP with a sphincterotomy, ampulectomy, EMR or ESD, dilatation of strictures, therapy of varices, back tube insertion, US with AFNA, esophageal enteral or colonic stenting. If you do have a low-risk condition, you can stop clopidogrel, preferably 5 days before the endoscopy. If the high-risk condition, like coronary artery stents, you can consider stopping clopidogrel, prasugrel, or ticagrelor for 5 days before endoscopy if more than 12 months after insertion of the drug-eluting coronary stent or more than 1 month after insertion of the bare metal coronary stent. For warfarin and direct oral anticoagulants, for low-risk procedure, you can continue warfarin, but you have to check the INR 1 week before the endoscopy. And if INR within the therapeutic range less than 2, you can proceed. If INR above the therapeutic range but less than 5, you have to correct the INR first. Direct oral anticoagulants, you can omit direct oral anticoagulants only in the morning of the procedure if it's a low-risk procedure. If it's a high-risk procedure with warfarin, you have to consider the patient, whether it's a high-risk condition or a low-risk condition. And if it's a low-risk condition, stop warfarin for 5 days before endoscopy. And if it's a high-risk condition, stop warfarin for 5 days before endoscopy and start low molecular weight heparin 2 days after stopping the warfarin. And you have to omit the low molecular weight heparin on the day of the procedure. Other societies prefer to be more than 24 hours. If an direct oral anticoagulant, you have to take the last dose of the drug 3 days before the endoscopy in high-risk procedures. These are the different practice guidelines classifying the procedure, whether low risk, high risk, or recently they classify also into ultra high risk for ESD, EMR, or large polyps more than 2 centimeters. And they classify the thrombotic risk as well for low risk or moderate risk or high risk or very high risk in case of antithrombotic therapy with acute coronary artery syndrome or percutaneous coronary intervention less than 6 weeks. And these are the different guidelines regarding whether the aspirin usage before the procedure, whether in low-risk endoscopic procedure or high-risk endoscopic procedure. Again, with low risk, you can continue, and with high risk, different societies usually prefer to consider aspirin discontinuation. Again, for thienopyridines, with the American Society of Gastrointestinal Endoscopy or even the European or the Asian, they classify into low-risk endoscopic procedure or high-risk endoscopic procedure, and they classify patients into low or high-risk cardiovascular risk. And again, with low-risk endoscopic procedure, you can continue the therapy. However, in the case of dual antiplatelet therapy, do not stop both antiplatelets, stop only a single antiplatelet. And with high risk, if the patient is low cardiovascular risk, stop just before the endoscopy. With high risk, discontinue thiopurine at least 5 days before or switch to aspirin. And discontinue thiopurine at least 5 days before endoscopy in the case of dual antiplatelet therapy with aspirin or clopidogrel. In patients with coronary stents, continue the aspirin and withhold the clopidogrel. Again, for the warfarin, they classified patients into low-risk endoscopic procedure or high or ultra-risk endoscopic procedure. And they categorize the patients into low cardiovascular risk or high cardiovascular risk. The issue is that you have to stop warfarin 5 days before the procedure and check the INR before the procedure to ensure values less than 1.5. Bridging with low molecular weight heparin only in cases with high cardiovascular risk. The same with direct oral anticoagulants. You can discontinue direct oral anticoagulants before endoscopy and take the last dose of the direct oral anticoagulant more than 48 hours before the procedure in high-risk procedure. These are the references. Thank you very much.
Thank you very much, Dr. Hany.